All right, now this is really as much as anything the focus of part two. I'm going to actually do a little bit of a review of some of the other stuff that I presented before, as opposed to last night where I just jumped right into what schools should be doing about their air. I'm going to sort of revisit some of the things that we were talking about. So, for instance, and one more time, I'm presenting my own views and not the views of any institution, district, or organization. So if there's a 1% chance someone is walking into your building, the answer is given to you right here. What is the total chance after 90 such days someone will have walked into your building with COVID-19? The answer is 64%. Now, I use 90 because that's hybrid, 90 days of school, half the time, so to speak. So here's the follow-up question. What if there's a 1% chance and it's 180 days instead of 90? Now you're dealing with an 84% chance. So the extra 90 days gets you some space, right, in your rooms, but it only gets you from 84 down to 64 in terms of the chances. And that's if there's a 1% chance that someone's walking into your building with COVID. But since I presented, the New York Times has put together a sort of interactive database that they use health experts and data experts to try and figure out, if you enter your county, what is the chance that on the first day of school, not even the chance, how many people do they think or estimate are likely to walk into your building with COVID-19? So if you use the county I am in, Mercer, and you give them the baseline of what the school is, and they'll put it up in a chart, you'll see it right here. In Mercer County, New Jersey, on today, if classes started today, first day, just the first day, if your school has 500 people in it, one person is likely to be walking through the door on the first day with COVID. 1,000 people, 2. Are those folks asymptomatic, spreading and possibly spreading the virus without anybody knowing it? Are they pre-symptomatic and possibly spreading the virus without anybody knowing it? Is it a staff member, a student? If it's a staff member, you hope it's not a super spreader, somebody who's these kinds of people they found who somehow managed to trigger outbreaks with 50, 60 people in a very small amount of time. You don't know. And remember, that's day one if school started today. And I wanted to get you folks thinking about the hybrid model. Here is a epidemiologist from Harvard, and he actually argues that hybrid model may actually be the worst option. It gets you physical space in your building so you can distance students in the classroom. But it means that the parents are very likely to have to get daycare in order for their kids on days when they have to work and they're going remote, etc. And so what happens is what Hanage talks about is that it kind of takes everybody out of their bubble. You control your bubble if you know you are the one doing the daycare. But if you're constantly exposing your kid to people on the outside, on and off, that actually maximizes the chances, he argues, of them getting the virus from somebody else and then potentially becoming a spreader. So hybrid might get you space, but it may very well be the more risky option in terms of contagion. So I'm going to quickly review some of the things again that I did last time and then have a brief break for us to talk. But I'm going to talk a lot more about the disease being more than just mortality and hospitalizations. I'm going to be talking closely related to that, to how much we don't know about the disease. A brief return to the comparisons to Europe and Asia and why they're weaker than you think. And then school outbreaks. So worse than you think. This is the description by somebody who was called a COVID long hauler. And what they're finding is that people who get COVID, even so-called mild cases, and then they pass the virus, right? They test negative, still have lingering symptoms, and they're not minor. If you read what Miss Oliver says, she describes the following: chest pain, like someone's sitting on your sternum; back and rib pain, like somebody's taken a baseball bat to your torso; fatigue so bad that it would often make me cry because I thought it might mean I was dying; diarrhea every day, sorry for the imagery, for 2+ months; unbearable nausea, delirium, and hallucinations. And that's what we call a COVID long hauler. And they're starting to focus more attention on that. We don't have complete data. Again, there's stuff we don't know. But the largest study finds that about 12% of the folks who have COVID, of 3.6 million users, 12% had symptoms that were longer than 30 days, and 1 in 200 had more than 90. So, I mean, you read the description before. I go on to survivors forums. Many people describe some or all of the symptoms similar to Miss Oliver from the last slide for 30 days, for 90 days, and going. I actually know 1 or 2 people who are COVID long haulers. So that's sort of one of the things that tends to get overlooked in the media. This could be something that we don't know yet. I haven't seen much for stats on children, but certainly staff members could get it. And then also children or staff members could bring it home to family members. Are you going to be able to work if you have that kind of condition? Is it going to affect your healthcare situation? But then there are also suspected long-term effects. So just within the last few days, I'll answer questions for folks right when this is done. So this is from just a few days ago, and this is the American Heart Association, and they're investing $2.5 million in research. Why? Because they're finding that there are vascular inflammation and heart problems resulting from COVID-19 that could be long-lasting. Here is a follow-up, and this is from the Journal of American Medical Association Cardiology, as well as stuff that was told to Infection Control Today. And this is also about studies on the long-term impacts of people who had it. It includes people from all different levels of severity. So some people who didn't even have really bad COVID coming down with long-term heart issues, and some of them were relatively young. And then you say, oh, well, that's 49. Well, that's around the age of the average teacher, and it's not just, as we're finding, unfortunately limited to people of the age of staffers. Here's a publication, Myocardial, that has to do with the heart. And I enlarge the key takeaway. Our case series reinforces the message that children with COVID-19 should be closely monitored to recognize cardiac involvement and prevent a severe and critical course of illness. You'll notice they're talking about something that's similar to Kawasaki disease, which is a cardiac condition. Well, just today, there was an article in the Patch that New Jersey is one of the 3 hardest hit states when it comes to coronavirus and this mysterious illness that appears to be causing swelling and heart problems. And by the way, this was on previous pages too: fever, abdominal pain, vomiting, diarrhea, neck pain, etc. But notably and most seriously, heart. And you're saying, oh, well, it's only 31 kids. Well, part of the issue, and we're going to get to this in a second, is that as we allow kids to interact with each other and with adults more and more, like, for instance, during school, are we going to have to worry about something like this becoming more and more common? And we'll see that, perceptions on how much kids are susceptible to this virus are starting to be challenged. We still don't understand fully the label asymptomatic. This isn't about heart, this is about lungs. And here's again, he's talking mostly about asymptomatic adults here. His work shows that even people with no outward signs of infection can be experiencing some temporary damage to the lungs. I can tell you that in other studies out of Arizona, they're just not sure if that's even going to be temporary. And again, you're saying, well, this is adults. And again, maybe you want to consider staff. Maybe you want to consider who's at home for both staff and students. But out of Florida, this is the director of public health for Palm Beach County. She is describing damage to the lungs of asymptomatic children in x-rays. Is that long-term? If you read the rest of the article, they're not sure. And all of these things remain to be studied. The question you got to ask yourself is, are the risks for children greater than we realize? Or do we simply not know what those risks are? And if we don't know what those risks are, and they can include things like long-term heart issues or long-term lung issues, do we have to factor that into our risk-reward calculation when it comes to going back to school? So it's not just the lungs and the heart. They're finding issues with the brain. Brain inflammation, symptoms that are ongoing. They have to investigate the long-term effects, and they're worried about post-intensive care syndrome, which can cause memory and thinking problems similar to Alzheimer's disease and psychiatric problems like PTSD. That's neurological complications from the virus that could, still has to be investigated, be long-term, but the virus is just starting. So you don't know how long-term it's going to be. And here, again, I've been trying to follow this pattern. Some of these studies focus on adults, but there are cases that have affected children, and it requires more study. Emerging research highlights a connection between COVID-19 and significant neurological effects in young brains. This is Nia Houghton. She's 15 years old. She's from the United Kingdom. And if you read here, she's describing things like waking up at night hallucinating, seeing and hearing people in the hospital who were not really there. I couldn't tell what was real. It was really scary. I could hear voices. It was very traumatic. How often does this happen? How young does it go? These are all things that have to be studied. The question is, are you willing to take risks and maximize risks? And we'll discuss that more when you don't know the answer to those kinds of questions. Here's Ryan McNamara. Dr. McNamara is actually somebody who's been very kind. He's gone back and forth with me in emails. I will tell you, though, that this was not meant for me. He put it up in the last 24 hours. It was meant for everybody. And he is a virologist who specifically has been working with COVID. That's what SARS-CoV-2 is. Just a reminder, death is one of many outcomes of SARS-CoV infection. Clearing the virus does not mean a full recovery to the patient's previous state of health. We have little understanding of long-term consequences of infection. Little understanding of long-term consequences of infection. And in the previous slides I've showed you, that includes people who got mild or were conditions or were asymptomatic. Do kids catch it? Well, we used to hear way back, say in April, it was presented in some places as it's almost impossible. Well, Just in the last 2 weeks of July, 97,000 children tested positive in the United States. That's before schools have widely opened. And that is a 40% increase in the states and cities in just those 2 weeks. And rather than sit and debate it, because people debate it, how infectious, are they more infectious? Are they as infectious as they usually are, which teachers will tell you is a lot? Are they less infectious? You have studies that go either way. Well, why don't we go to the actual source? If students are not infectious, why did South Africa have massive outbreaks? I don't know. Maybe there's another answer. But 968 schools closed due to outbreaks, 2,400 teachers, and 1,260 learners. If kids are not susceptible to the virus, how did that happen in just 1 month? In fact, by the way, South Africa had to close their schools after a little over a month because of what COVID was doing there. And South Africa is not the only country. There's Israel. And Israel, by the way, had completely crushed this virus practically. I mean, they were doing an amazing job. They opened schools and they became lax on the measures inside of the school. South Africa opened schools when there was still community spread, when there was still virus outside of the schools. Israel opened them when community spread was largely under control, but they got lax on what was happening inside the schools. Well, you hear the numbers here, 125 schools, 258 kindergartens closed, 691 staff, 1,335 students infected, plus the secondary effects. Now, in Israel, the epidemiologists have said that they believe that the educational institutions are in fact largely the source. It certainly represents the plurality of places that, and this was really a phenomenon, especially last month, that were having outbreaks of COVID-19. And I enlarged that article, and if you read here, the epidemiological surveys by Israel's health ministry indicate that a spike in infections occurred among the country's youth that later spread to the general population. One of the public health officials resigned. He said, he was an epidemiologist, much of the source of the second wave stems from the opening of the education system in a way that was not adapted to corona and mass gatherings, becoming lax about social distancing, masking, things along those lines. So again, judge for yourself. Do kids spread it? Can they get it? I have talked about this before. This is a couple of weeks old, but these figures are largely the same if you review them now from the site that I went to, COVID projections. The point I made in putting up this slide is a lot of times we talk about places, we don't talk about Israel, but we talk about other places that open and wow, they did so well. Very few outbreaks in Europe. Not many outbreaks in Japan or in Asia. And what I'm trying to show here is that if you go on a metric called effective reproduction rate, which is a measure of the trajectory in a community, the trajectory of the virus, that epidemiologists, it's one of the metrics that they use. When it's below 1, it means you're bending the curve. And when it's 1, the curve is kind of flat. That means the disease is holding steady. And then if it's above 1, that's not good. That means that the virus is growing. And if you look at European countries, Australia, Japan, you'll see that in almost every case, when they reopened with a RT below 1. The United States now is at 0.95. We're very close to 1. It depends on the area you're in. And if you look at this chart right here, you'll notice, and this is from today, this is from just within the past hour. Yesterday, we were the 3rd worst, by the way. Today, we got a little bit better. We're down here at around the 10th worst state in the union when it comes to effective reproductive rate. You look up here, Arizona, isn't Arizona a disaster? They really got scared into doing the right things. So they're getting the disease curve under control. The one I want you to pay attention to is the 11th one over here. The 11th best in the country is Tennessee. Remember that. New Jersey is the 10th worst, and Tennessee is the 11th best. I want you to remember that. Again, if the community spread, just one more time to highlight this, this is a measure of how the disease is doing in your community and your state. If community spread is high, like it was in South Africa, and you reopen, you're running the risk of bringing the virus from outside of the school into it and then back out again. Israel, the problem again was it wasn't community spread. The epidemiologists there believe that it went from inside the school, grew, and went outside. But I want to focus on that Tennessee versus New Jersey. So a CEO of a company called Maneri, Dr. James Hildreth, he's a doctor and, a doctor who runs a hospital system. He gave a speech today in Nashville. It's pretty potent, but I wanted to highlight the key things here. First off, this is a great segue. This is my last slide. He is very concerned about schools reopening. Why? Because a new study from the University of Florida indicated that the COVID-19 is in the air. And in a much better air-controlled environment like a hospital, it was a problem. And as Dr. Hildreth said, what's that going to mean? In a more enclosed space with a poor ventilation like schools or churches. And listen to what he said. Again, this is a doctor who's advising a city about whether or not it should reopen its schools. In a state that is presently doing better, at least according to effective reproductive rate, it's not the only statistic, but is doing better in some ways than we are at controlling community spread. And here's what he said. It is now beyond dispute that children can be infected, will be infected. Some of them will get sick, and unfortunately, as we know, some of them will also die. I'm not doing this to try and fearmonger. That is his words. So I want you to take that into account. I'm going to take some questions here, and then I'm going to dive into the issue that Dr. Hildreth is highlighting, which is particles found in the air. And I will stop for a second. I will stop sharing, and I'll take some questions if you have them. Anyone, questions? No one in the chat? I don't see any.
Stu, just a question. That one slide you had, Danny Oliver, was she just a citizen?
She's just a citizen in New York who's describing her own ordeal with COVID and the long haul.
Wow.
And again, things like pain in the sternum and feeling like you're dying. And that's not an exception. You can go to a COVID survivors group on Facebook, and it's frequently a topic of conversation. You know, I'm 40 days in. Why do I still feel so fatigued that I have to sleep for 3 hours in the middle of the afternoon every day? You know, I'm 50 days in. I used to run half marathons. I can't jog around my block without losing my breath anymore.
Right.
So,
okay. Yeah, because I spoke with some folks today from Pennsylvania, and similar, the long haul, that just debilitating exhaustion, For one, it was just a hacking cough that won't subside. Is there a trusted site you recommend for COVID long haulers? Just to find out more information, a particular site you recommend?
So there's a great group on Facebook called COVID Survivors. It was
Okay.
actually organized originally to try and rally up COVID survivors to donate blood plasma. But what it's become is more of a support group. And on many threads, but certainly you can dig up, I could probably dig up, I think I've stored some for research. There are people who will say, hey, this is what I'm going through. What have people tried to do to get through it? And, people will make recommendations about the kinds of things they've done to try and muddle their way through the COVID long haul. So it's COVID Survivors, I think it's called, on Facebook. And you have to apply, but they'll let you in, I believe. They let me in, and I didn't have COVID. So,
Great. Thanks, Stu.
anyone else? Questions?
There is a question in the chat.
Well, that is going to be part of our next presentation. The immediate answer to your question is, I don't know. I think we need to get people in East Windsor and Hightstown and every school district across the state, as I will explain, really need to find out that information and compare it to the recommendations and the sort of guidelines that experts have put out. And that is really going to be my next, the focus on my next presentation, because if we don't measure up, remember, the ventilation issue, the aerosol issue, was enough for the doctor in Tennessee to say, and he gets pretty hardcore, you shouldn't be opening schools. Because many schools are in old buildings with older HVAC systems that haven't been upgraded. They're not built for natural ventilation. That's something that I did an update here, but a doctor today pointed out something that I pointed out 2 weeks ago about the European schools. They're in buildings that were designed for natural ventilation, and that is an advantage in combating a respiratory virus. Our schools and our buildings are almost all built for mechanical ventilation, and many of them are very old. All right, does anybody have any other questions, or would you want me to go on to the next part? Give it a few seconds here. All right, I'll take that as my cue. So let me go to part 2. And this is where I get much more focused on the issue of ventilation. So let me present. Many of you will be familiar with this slide. My focus is on modes of transmission and really the aerosols, but there are surfaces, fomites is the fancy name. That's why we wash our hands. That's why we wash tables and chairs. There is droplets. So when you cough, that's like the droplets of saliva that you can see and that actually, you can feel on a tissue. And we combat those primarily with masks, but to some extent distancing as well. And then there's aerosols, which are tinier particles that are much more difficult to see, that float in the air, and can in rooms where the ventilation is not up to par, where the air is stale, they can hang there, sometimes for long periods of time, and travel even beyond the 6 feet of social distancing. Again, to visualize it, these are droplets. These are aerosols. And as you'll see in some of the experiments I'm going to show you by video, aerosols actually have to be backlighted. There's dye that has to be used so you can look at them and test them. And we'll see some of that. I've shown this to folks too. Again, this is the World Health Organization, WHO, the 3 things they tell you to do to avoid crowded places, avoid close contact settings, avoid confined and enclosed spaces. Now, maybe you're optimistic and you think the schools can handle crowds, you think the distancing is going to be maintained in the classroom, that when the students go into the hallways, they're going to be vigilant about how they go into those hallways, or somehow your school is going to move the teachers instead of move the students. That would really be something you could only do, say, in elementary schools. Maybe you think that when there's a drill or cafeteria, that the students are going to maintain their distances from each other. They won't make it crowded. Close contact settings. Maybe you have faith in that. Maybe you don't think students are going to go to the bathroom at the same time so that they can take off their masks, talk to each other. Boyfriend and girlfriend might do something, etc., during a break. Maybe you think none of that's going to happen. But you'll be hard-pressed to get away from closed and confined and enclosed spaces. Basically, that's every classroom. And, ventilation, that's something that's beyond many people's control. Now, maybe schools can do something about it. I would submit to you that we're running out of time, and we're probably in a situation, as I'll get to explaining, where many schools cannot meet the standards for ventilation that are being recommended by expert group after expert group. And part of what I'm going to do is assemble for you in one place, after going over it a little bit, all of the groups that are giving very similar recommendations. Now, why do you have to worry about closed and confined spaces and poor ventilation? Well, I wrote a Japanese building scientist who is part of the Science Council of Japan, which helped reopen Japan, including their schools. And again, questions from a teacher about COVID in school buildings. And I asked him, and this is the focus, the question I asked him here, suppose the students are 6 feet apart and suppose they're wearing masks, but suppose also that the ventilation is not up to par, the air is stale. And what did he tell me? Is it safe? I asked him. It is unsafe. The mask prevents the spread of large droplets, but it does not necessarily prevent the spread of aerosols. And you need ventilation as a countermeasure for that. And we're going to illustrate this. By the way, number 2 was, well, what if it's young people? And look what he said. Again, the kids, he said, can infect parents, teachers, grandfathers, and grandparents. Even if, as the statistics thankfully say, hospitalization and death mortality seem to be less for students. We don't know all the long-term things yet that I described before, even for asymptomatic kids. And we're really taking a risk, I would argue, with how much the students are going to potentially spread it. But we're focused again on aerosols. Here is another expert from Japan who uses supercomputers to figure out how to reopen buildings and schools. He just echoes the same thing. For larger respiratory particles, social distancing and face masks are adequate. But with rooms with dry, stale air, his research showed that people coughing, sneezing, and even talking and singing emit tiny particles that defy gravity. They're able to hang in the air for many hours or even days and travel the length of a room. As the professor in the last slide said, that's why you need to intervene with the air systems. And I am actually going to illustrate this to you with an animation. So just recently, this company called HOLT Architects, they were reopening their offices, and they wanted to make sure that they were keeping people safe. So as you'll see, they hired and worked with, because they have backgrounds in this material too, a computer engineering firm with fluid dynamic algorithms to figure out what's the best approach for them to open up their own buildings and keep their own people safe. I think this is going to be eye-opening for you. Now, this is no masks, and you're saying to yourself, well, all our kids are going to wear masks. I ask you to hold that thought for a couple of slides because I'm going to show an animation of what happens when the mask is not fitted right and isn't a high-quality mask. But even if it is, I want you to pay attention to what they did with no masks, because it's still better. Mask is still better than no mask, but also because many schools are going to be having kids eating lunch in the building. Now, from what I know about schools, it's going to be 30 to 45 minutes. Watch what happens in 10.
A few weeks ago, we mentioned that here at HOLT Architects, we were going to be completing a computational fluid dynamics study of our office here at 619 West State Street. And in just a moment, I'm going to share with you some of the first imagery from that model. ME Engineering out of Syracuse, New York has assisted us with building a virtual model of this office space you're looking at, our open studio. And in about a moment, we're going to simulate a person infected with COVID-19 sitting in this workstation right in this location and begin to see how infected droplets might move through the studio. We modeled a number of scenarios trying to decide how HOLT Architects would return to the office. Staff wanted to know if they'd be allowed to remove their masks when seated at their workstations. And for that reason, our first model represents an unmasked person coughing 3 times in about a 10-minute period. You should note that anywhere from light blue to red represents the HID 50, or human infectious dose for COVID-19, and red is 5 times the human infectious dose. Notice that a cloud carrying a dosage 5 times that HID 50 is carried 30 feet across the studio, and a normal infectious dose can travel more than 50 feet indoors. Finally, notice that the cloud of virus never reaches the mechanical system where filters could be effective. The first model gave us absolute clarity when deciding that all of our staff would be required to wear masks at all times unless in a single occupancy space with the door closed. Our next step was to determine under what other terms would we occupy our office, even with a mask mandate. We'll show you in our next video why 6 feet of distance and a mask may not be enough when indoors.
I'm going to show you that. I want to reiterate one more time. This was 10 minutes with no mask and 3 coughs. Remember, New York Times said, likely, based on our conditions on the ground, that if you have a school of 500 to 1,000 on the first day, somebody is walking, at least 1 and possibly 2 people are walking through your building on day 1 with COVID. Okay? So what about masks? Remember what the Japanese experts, one told me directly, another talked to a magazine, said. Distancing and masks are not enough. Well, let me show you what happens here.
Hi everyone, we're back again to share more of our computational fluid dynamics study with you. As you might recall in the last video, we shared how our model of an unmasked person coughing in the studio 4 times in a 10-minute period compelled us to have a 100% mask mandate in our office. That is, our staff would wear masks at all times in all office public areas and would only be able to remove masks in single occupancy rooms. So the next logical step was to model a masked infected person in our office to first determine if we had an issue, and then secondly, begin to consider architectural mitigations. In this second animation, we've modeled our infected individual coughing 4 times in the same 10-minute period. The first notable thing here is that compared to the last rendering, the red cloud, which is 5 times the human infectious dose, instead of being transported 30 feet across the studio, is almost completely contained to the immediate workstation. However, and surprisingly, the light blue to green cloud, which is between 100 and 300% of the human infectious dose, can still travel more than 20 feet, with some of the cloud traveling even 50 to 60 feet. The conclusion here is that if you're indoors for an extended period of time with someone who has contracted the coronavirus, 6 feet in a mask could be a false sense of security. The mask is extremely useful in containing a droplet cloud, but it's not 100% effective. Those leaked droplets, as we've illustrated, can travel at least 30 feet in a cloud. And yes, being exposed to that cloud for just a few seconds might be harmless, but in an office environment where you sit for hours, you could have a high likelihood of inhaling those droplets even while wearing a mask. There are ways of greatly reducing the risk of transmission, like more air changes, diluting the indoor air, compartmentalization of space, and even light sterilization. And in our next video, we will begin to discuss some of those ideas.
I'm not playing the next video, but you'll see that multiple additional experts confirm exactly what he says. You've got to do stuff about the air, things like ventilation, HEPA purifiers, get the airflow moving in the building and cleaned and purified. So again, I just want to reiterate, that was 10 minutes, folks, and they were masked. And to illustrate some of the potential limitations on mask, I'm going to show a video one more time than I showed to you folks, if you've seen this presentation before, about what happens when the mask isn't properly fitted, what happens when the mask style or fabric isn't necessarily correct. You'll see. And then again, ask yourself this question. Maybe you are somebody who will be very conscientious about your mask. Maybe you'll be somebody who has the right kind of mask. But will every student be conscientious of the mask? And I argue staff. And will every mask be the right quality? Think about that as you're watching this. And remember those previous two videos that I showed you. I real quick want to pause and mention that this is being done. TU Delft is a public health engineering university in the Netherlands. So what they do is they take a mannequin type head and they give it what amounts to a breathing simulation system. And they put a mask on that's not properly fitted. And look what's happening to the aerosols that are being backlit. How long do they stay in the air? We don't know. How many feet do they go? Now they're going to show you what it's like without a mask, which is a big no-no. You should always be masking. And here you still have leakage. I'll let it play in the interest of now. Here's a better fit and better quality mask, but they'll tell you, you can't see it, but they're going to tell you less leakage. That's not no leakage. And you add those three videos together, I think they make a very compelling case that we need to be very conscientious of what's happening with the air, even with masking, even with 6 feet of distancing. So just to let you know, more and more studies in the last months are showing what I've been talking about for the last few weeks, that you get droplets with enough infectious material to stay in the air for minutes hours. Here, the person demonstrates inhalations, another word for aerosols, basically, that in a healthcare provider setting, they can actually be a likely contributor to a meaningful risk of COVID-19 in a healthcare setting. And as the doctor from Tennessee told you, that's more likely to be sterile and well ventilated. And then this is the so-called smoking gun. And this is, in fact, the study that the doctor was looking at. And it shows that not only do the virus float in the air, it contains enough virus that it can infect somebody. And here's Lindsay Marr, who I've had a little bit of a give and take with. And before that, she gave this, and she said, this is what people have been clamoring for. It's unambiguous evidence that there is infectious virus in aerosols, in little invisible particles that can float, that can escape a mask, hang in air, travel the distance of the room, that you need to figure out what to do about. You need to do something about it. And this is Dr. Ali Nouri. Maybe some of you have gone to a pediatrician or something and they've told you they don't buy the aerosol thing. What Dr. Nouri is telling you here is that there's a built-in, but he's saying this on July 2nd. It's not, the science has changed since then. There's a natural predisposition by the medical community against aerosols causing virus to spread. But I've already shown you that in the past month and a half, that's been dispelled. Why is Nouri amplifying this, and why am I pointing him out? Because he's a microbiologist and the president of the American Federation of Scientists. And he is amplifying the issue of aerosols. So you could, pediatrician expresses doubt, point to the doctor from Tennessee, point to Dr. Nouri, point to Lindsay Marr. There are many, many doctors. This is sort of the trend for the last month, and it's why I've been doing presentations. You'll note many of my presentations came not long after July 2nd. So what do you do about it? So NIST is, I think, it's the National Institute of Standards and Technology, or Science and Technology. And they did a compilation across government and other related agencies for what they're suggesting. So some of the things I've underlined: MERV 13 filtration. That's the sort of the fiber sort of matrix on the sort of squares that you put into your air conditioning, that you would put into your vents and your HVAC. It's sort of the thread, right? And how tight it is. And that mesh, how well does it do? The higher, the better. As you'll see, I'll put it in another slide. That's the kind of mesh you're going to need in your HVAC in order to capture the virus, because the virus comes in a particular size. All these groups, I'm going to show you what ASHRAE says just because they're so important, because they're the Society of Refrigeration and Air Conditioning Engineers, but also the U.S. Department of Energy. APA happens to be the sort of go-to group for air quality for colleges and universities. They're recommending portable air cleaners. They're recommending that you check your airflow, like figure out what's going on and monitor it, and maintaining 40 to 60% relative humidity. All I will say is maybe you don't have to wait for that, some of these things. Ask your teachers and ask your students if they've been in rooms that are either excessively humid or excessively chilly, which is still humidity, but with cold applied. Ask yourselves, ask your students, ask your teachers in your district, in your buildings, have they been in those rooms? Because that's a pretty darn good sign that you're not going between 40 and 60% humidity. But it should be measured. Why? Because COVID is so small, you need high-grade MERV filters in order to capture the virus and prevent it from recirculating in the room or going into the HVAC and potentially going into other rooms. So I'm going to start listing some places that aren't even in NIST. They came out after NIST put together their compilation. So here's Harvard's very prestigious School of Public Health, the T.H. Chan School. What do they recommend? MERV 13 or higher filters, air cleaning devices, humidity between 40 and 60%. Those are going to become very familiar. The National Academy of Sciences amplified what Harvard said, talking about HVAC systems. Here they are talking about the need to even repair. That's the National Academy of Sciences. In both the case of Harvard and the National Academy of Sciences, you're talking about elite experts from multiple fields coming to a consensus on what schools should be doing to reopen. Here's ASHRAE, the leading group of experts on air, the air engineers, so to speak. Here they are. They're echoing the issue about aerosols. They're saying MERV 13 or greater. Here's the EPA. They are not in NIST's compilation. They're saying MERV 13 or better. MERV 13 is the minimum. MERV 14 is preferred or higher. HEPA is even better. All right. And here they give more detail. You'll see some of these are familiar. MERV 13, MERV 14, portable HEPA. But somebody else agrees. That's Governor Phil Murphy. So he has actually posted and talked about a study of a restaurant in China. And the mystery, or what would be a mystery if you weren't using aerosols, of the fact that groups of people who had no contact with the index case, the person who was spreading, and were more than 14 feet away from said person, were getting sick from that person. How did that happen? Well, Governor Murphy says it's the air conditioner. It's like the jet stream from the air conditioner that's causing it. And here he is just a few days ago. Airflow is a constant concern. This is why we've been much more forthright in reopening outdoor activities, including outdoor dining, while limiting indoor ones. The NGEA is onto this. Here is their minimal acceptable standards. Now, they added inspection, and I want to talk about that because that's really important. They're up to 17, and again, 40 to 60% humidity. Now, when it comes, and they have some other things listed here, when it comes to the inspection, I've talked to Jeff Smith, who is an air quality consultant for the WHO. I've talked to him for hours. He's very generous. He has helped open schools around the world in unhealthy environments, and he gives certain qualifications here. First off, if your school says we ran an inspection or is going to, you need to make sure that they ran the HVAC, they ran the air the way it would on a school day. In fact, the way it would be on like a winter day when you have to close the windows and run the heat. Otherwise, you're not really simulating or measuring the air the way it is on the day you need to. There actually must be people breathing air before you start measuring. So you actually have to put a small group of people into the room, let them breathe, possibly talk. Again, the air has been running for an hour, and then you start taking measurements. And you gauge CO2, humidity, airflow. These are some recommended numbers. I've seen a little bit more lenient for this sometimes at 800 parts per million. At the same time, I've seen less lenient than this at 54 M3. But those are the kinds of numbers you should be looking at. And then you need to get consistent 40 to 60% humidity, and you need to consistently measure it. It's not like you stop in September. You got to do it in October and November, maybe weekly. This is from a person who does this for a living. And I would submit to you that you need to make sure that if your schools are doing a audit of the air systems, that they are looking at this exact kind of process. So I've put all of the stuff in one place, and I'm probably just going to post this slide for people. If you want to send something to somebody, whoever that may be, and tell them, look, all of these groups have said this is what you need to do to open schools. And then maybe point out, and that's going to be my last slide, that even the governor says that airflow and ventilation is a key issue. How can your school put you into buildings that don't measure up to the standards that all of these expert groups have said need to be met? This is, again, just my opinion, not representing any organization, union, etc. But the virus does not compromise. If you can't handle in your HVAC system MERV 9 or higher, the virus isn't going to get larger for you. If the humidity in your room, you have a real difficult time getting it even below 70%, the virus isn't going to make it in compromise with you. These are, and the NGA put it up there, the minimal standards. You would not go into a building that was kind of okay when it came to a fire hazard. And I just have to end with this quote from just a couple of days ago. Indoor movie theaters are hard, Murphy said Friday. You can social distance, you can mandate face coverings, but you're still sedentary. You're subject to the ventilation of that particular theater. I don't want to take bets on which ventilation systems are going to be better. Newly built movie theaters with much bigger ceilings, or a small enclosed classroom in a building that is, for a large number of buildings in the United States, 60, 70 years old. You folks figure that out, but don't even figure out. Demand to know these things, quote these things, and ask for some kind of resolution. It should be, the building should be treated, if it's a building that could have COVID in it, should be treated like a hazard, like a fire hazard. If you don't have nearly enough, air sprinklers in your building, and you know that the building could light on fire, you're going to do something about the sprinkling system, or you're not going to go in. That's just my thoughts. I welcome any thoughts from you folks, and let's talk. Do you know if the here's what I know. Materials have been presented to certain superintendents in my local area. I shouldn't say superintendents, certain officials in my local area. I cannot promise you where it's been cycled to or not. I cannot tell you if people have taken that from my presentation and put it and addressed it to the people in question. I'm limited in the kinds of things I can say. All I'm willing to say is make it a point to ask, does the school have all of the following things from all of the following, recommended by all following agencies? And if they say, we only got to A, B, and C, and this, I'm talking about every district. We can't do this. We don't have enough money to do that. You don't, again, this is just me. The virus doesn't compromise. Thank you. Absolutely. I thank you. Is MERV 13? So different groups put different, the higher the MERV, the better. Many groups say at least MERV 13 as the minimum. Some say 14 is recommended, but 17 is better than 13. The higher, the better. And NGA says 17. They should probably stick to 17 because it's better than 13. I do not know what East Windsor has. I'll just say in general and draw what inferences you want. I'm fairly confident that virtually no schools have MERV 13 and virtually no districts. Private schools have upgraded, by the way, like the Hun school. So like when you call, say, your county superintendent in any given county, you might want to know, and I can tell you, again, I've heard the Hun school has done it. Hey, the private schools in our county have made all of these upgrades. If they're doing that, how can we justify sending students into buildings that don't have them? And if they say, well, the private schools have the money and the resources, the virus doesn't change because the private schools have resources and public schools don't. Again, I can't really talk more about it. So we have engineered the retrofit of 10 million of SF, I'm not sure what that stands for, of New York City office buildings with most of these recommendations. However, maintaining 40% humidity for most pre-2000 buildings will cause mold, which is harmful to people and create. One other strategy we are using, oops, my battery's running low, I'm sorry, let me reread that. Is using a former mayor's building as a technology called bipolar ionization. All I'll say is when the word ionization comes up with some of the air engineers that I talk to, they get a little bit sketchy and say that there's issues potentially with ozone. But I will say also, you say 40%, I'm wondering, and maybe you can answer, is 60% doable? Because I've seen between 40 and 60 as the recommendations. So some people have reported rumors that East Windsor has MERV 8. I can't confirm that. And others have said it might be MERV 7. So I don't know. I would say this about multiple school districts, deeply skeptical that they have MERV 13 or higher, and higher is better. And by the way, that's why, purifiers need to be in the equation too. The air engineers almost all say that purifiers in every room if you want to keep things safe. Now, by the way, if you do these kinds of things, they may be expensive. And you might have to wait for the federal government to give you, which is in the stimulus if they ever get to it, between $1 million and $1.75 million per building on average in the United States, which could be higher for larger buildings or more needy districts. If you need to fundamentally upgrade your HVAC, you might have to do that. If you have to do a lot of repairs, you may have to do that. If that's what you need in order to get a HEPA purifier in every room, you may have to wait. So the question is what are you going to do while you're waiting? You're going to force people into, I don't want to say force, I shouldn't use that term. Are you going to put people into the rooms and the buildings that don't meet the standards while you wait, or are you going to come up with some other solution that's safer? Anyone else, any questions? I would say one other thing, folks. If you follow news, we just have learned about a partnership between Yale and the NBA that's likely to get us large numbers of very cheap, very fast tests that are pretty high quality. Now, maybe that takes a couple of months, but that would potentially allow you at first within a couple of days to find out, 1 to 2 days, what your situation is. But they're talking about possibly even getting to a point where you can find out just in your own home. And that will allow you to know on a consistent basis they're going to be cheap from everything that people says, whether or not somebody's got, contagious virus or not. And that would, if you have faith in each other, allow you to potentially do a lot of things that you weren't doing before. And I've seen figures that maybe in a month, maybe 2 months. I'm not saying that's justifying opening, but I'm saying it's something that you want to think about. Bill Gates has said that he thinks therapeutics and treatments, not a vaccine, but some pretty good ones may well be on the market by the end of the year. And Tony Fauci and others have said there's a chance. I don't want to put odds on it because vaccines are tricky. There's a chance that we'll have a vaccine by the spring of next year. So I just want to think about the logic here. All those conditions that I put up there before that may or may not be common, in children, things that we know are more common with adults and the staffs in buildings, and with the older people who you're coming home to from schools. Who wants to be the person who says to somebody who got long-term heart damage from COVID in November, hey, who wants to be the one to say in April, we sent you into buildings and you got COVID and you got this long-term heart condition, but on the bright side, the people who are getting the treatment now in April aren't getting heart damage. When all you could have done, all you had to do was wait. You can make up education, folks. People can go to summer school. They can get tutoring. I would imagine, I hope, that colleges offer remedial programs. There are junior colleges before you get to colleges. Teachers will all know that everyone experienced the pandemic and that some people need additional help. And I know it's tough on some families as well. But I would say that the health repercussions of going into a building, which I think I've established is not a safe place if the ventilation isn't good, or might not be a safe place. What happens to the same parent who has to go work if their kid gets sick, or if they get sick and become a long hauler? That's not going to be good economically either, and that's not equitable either if working class people are the ones who have to bear the burden and the risks of getting the disease. So I'm suggesting that maybe waiting for some of these things to happen that can mitigate against the virus is the prudent thing to do. We have asked for the OPA report from our school. What else can we actually push for that they have to do in order to? I think you need to get an air quality. I'll go back to the slide. I'll go to 2 slides because I think they're almost the 2 big takeaway slides from my presentation. You have to get an inspection that does something like this, that gauges, that runs the air like it would be on a day that people are in a building under normal conditions, that put people in rooms. You need to do it in almost or most rooms, and if you're doing most, that needs to be randomly sampled. You need to do hallways, you need to do bathrooms and offices. You need to just get the figure on the CO2. We'll worry about how to get it to the lower numbers afterwards. You need to get, same thing, a reading on the airflow in all these rooms and hallways, and you need to get a reading on the humidity in all these rooms and hallways. And you need to make a plan to keep on measuring it. But this has got to be your starting point. You got to get an inspection that gets CO2, airflow, and humidity in basically all the rooms and hallways and bathrooms in all the buildings. I don't know how much you folks trust your administrators or not. Maybe you want to get people to sign a document that say they did this before they give you a readout of all of that information. Maybe you get the board president to sign. Maybe you get the superintendent and all the building principals to sign and the inspector to sign. I'm just pontificating here. I'm not saying that's what you have to do or what have you, or even that's what I would do. And then ask for the hard data. Once you get confirmation that they've done this, ask for the hard data and get it certified. And then step 2 is say, if they don't meet these standards, to fix all those relevant problems, find out what they have here. Do they have MERV 13? Do they have true HEPA purifiers in it? Enough for every room? What's the humidity? This is, you gotta show them what all the experts have been saying for 2 months or more and demand it. I would argue, for me, from my point of view, demand this. Don't accept less than this. This can't be a negotiation. Just speaking to the idea of unions, right? This isn't a negotiation for, you know, something that you put in your pocket because you gave them MERV 9. You expect them in a year to give you fewer PD hours. Like, this is health. I mean, this is just my opinion. I think it's non-negotiable. And I will post those 2 slides ASAP.
Marcia, I think you were right. Stu just texted us and said that his laptop died. So you were right. Thank you so much. But he wanted to thank all of the participants, and he said that he is going to post stuff. So Marcia, if you wanted to take it from here, I just got that text from him.
Oh, thank you. Okay. So thank you so much. And thank you everybody for attending. I think that we can all perhaps thank Stu under the event or under the mobilized post there, because I mean, he is doing a remarkable job keeping us all really well informed. If you have any remaining questions, you can feel free to send them to me on the Facebook under the mobilized page, or you can email me. I'm going to put my email in the chat right now, and I will get those over to Stu. It's marcialdaly@gmail.com. It's in the chat now, so if you want to copy that, if you have any more questions or concerns that you'd like for Stu to address, things that you think maybe he can do or should do in a next talk, or if you have questions about one of the updates, we are definitely going to get some of this edited, the recording edited, or have his slides so that we can view them in the mobilized page. And if any of you aren't on the Mobilized for School Safety Facebook group, just again, you can email me there, and I'll show you how to find it. But if there's any other questions or anything like that, feel free to contact my email or on the mobilized page. All right, thank you all so much for attending, and I hope you have a great night.